recruitment maneuvers are 1 minute, huh? Hold on. All right. So recruitment maneuvers are something that we are giving to patients of ARDS is what we understand. All right. Now, why do you recruit these patients? You recruit these patients for two reasons. One reason is to improve the oxygenation. One reason is to improve the oxygenation, and the other reason is actually to improve the compliance. Okay, there are two reasons. You can't say that it is only for oxygenation. It is also for improving the compliance. Now, there are two aspects to this. The compliance per se. So, if somebody asks you, will you recruit every patient? So will every patient will respond to a recruitment? No. There are two kinds of patients, two categories of patients in a recruitment maneuver. One that responds, and the other one that does not respond. Okay. Clear on this? There are two categories of patients.
Yes,
One
sir.
that
Yes, sir.
responds, and the other one that does not respond. Okay. Now, how can you understand if this patient will respond or this patient will not respond? Because recruitment has not shown to improve mortality or outcomes. Recruitment has till now not shown to improve mortality or outcomes. So this means that you want to use this maneuver only when you feel that it is safe, isn't it? That is the most important aspect of this maneuver. I mean,
Sir,
as a doctor, what you will,
hello, sir.
yeah, yeah, Anant. Okay. So, what is the most important thing about this maneuver is that if you want to do this maneuver, you have to be doubly sure that you are not going to cause harm. That is the first and most important part when you're dealing with a recruitment maneuver. Clear on this? Okay. Now, because specifically this recruitment maneuver does not improve outcome, does not change mortality. None of the recruitment maneuvers till now have improved outcomes or changed mortality. So, but still we know logistically that opening the lung and keeping it open is something that we want to do in our patients. Otherwise, they will go bad towards. Absence of evidence does not mean that there is no evidence. Logically speaking, we will still need to open up our lungs. If the oxygenation just goes on keeping going down, or the compliance just keeps on worsening, 100% the patient is going to die. And that is the time when we try to use a recruitment maneuver. So the prerequisites for a recruitment maneuver is that there has to be a normal blood pressure, or there has to be some kind of stability in a blood pressure. You can't have a blood pressure of 70, 80 systolic or a 90 systolic blood pressure and go ahead and perform a recruitment maneuver. It is absolutely foolish to do that, because what will happen is, if it was 90 systolic blood pressure and you do a recruitment maneuver, there is going to be a huge rise in intrathoracic pressure, and this rise in the intrathoracic pressure is going to reduce the venous return. The reduction in venous return is going to cause drop in blood pressure, and that drop in blood pressure will affect your recruitment, will affect your mortality. It has been proven that even 1 minute of drop in blood pressure will cause renal injury. Even 1 minute of blood pressure drop will cause renal injury, and hence that even 1 minute of blood pressure drop that will occur during a recruitment maneuver may be extremely dangerous for your particular patient. Most of your hypotension responses when you do recruitment gets amplified when there is hypovolemia. So the second prerequisite is that the patient cannot be hypovolemic. Patient has to be euvolemic or slightly hypervolemic when you are performing a recruitment maneuver. You cannot have the patient in hypovolemia when you are going to do a recruitment maneuver, basically because if the patient is hypovolemic, again the same logic comes in, the venous return will reduce, and low venous return is responsible for causing a low blood pressure. So all the hypotension that you get after a recruitment maneuver will be amplified if you are hypovolemic, and that's the reason that a hypovolemic patient is not a right candidate for recruitment maneuvers. The third prerequisite is that the patient should be calm and quiet. You cannot have a patient who is bucking and coughing on the tube when you're doing a recruitment maneuver, because it will not help to improve the lung compliance or improve oxygenation, because you need the lung to be passive. You need the patient to be ideally passive, ideally paralyzed. Ideally paralyzed. More or less, if you look at it, whenever you are going to ventilate or recruit your patients, they are going to be paralyzed at that particular moment when you're attempting a recruitment. So remember this, that it's normally after after you have intubated a patient that you want to recruit your patients. That is why they are usually paralyzed. So it is best to do a recruitment maneuver when the patient is paralyzed. You don't need the patient to breathe when you are having a recruitment maneuver, because it might lead, if the patient is very conscious, the patient might cough, might buck on the tube, and that will cause a release of pressure and failure of your recruitment strategies. Okay, so so that means we need to figure out which are those patients that is going to respond versus those patients that is not going to respond. For example, you have a patient who comes in with a pneumonia. It's a lobar pneumonia that comes to you, and patient is kind of hypoxic. His PF ratios are 150. Now, you must understand that a lobar pneumonia will not recruit better than a multilobar situation, like a diffuse ARDS. You understand? So if you look at a chest X-ray and you get a lobar pneumonia and there is hypoxia, you have intubated and you have ventilated this patient, you must think in your mind that this is not the patient that will probably respond to a recruitment maneuver. Why am I saying it this way? Because it is lobar, it is not diffuse. What is the definition of ARDS? ARDS means diffuse multilobar infiltrates. Diffuse multilobar infiltrate. So do not try to recruit every patient that has hypoxia. Because of the fact that recruitment is, first of all, does not improve outcomes, and it can be extremely dangerous. For example, the shear stress that develops between a collapsed alveoli and another adjoining alveoli can be to the tune of 137 centimeters of water, PEEP of 137. You understand? That is the, there were certain scientists who looked at what could be the shear stress between two alveoli, one collapsed, one open. And they found out that the shear stress could be 137. Okay, that's a very high number. Very high. Imagine PEEP of 137. You can just imagine the stress that is there on that particular lung. And that is a reason that lobar pneumonias, which will have areas which are consolidated because of diffuse infiltrates, versus, and the adjoining areas will be good. Adjoining areas will be good, and that will cause extreme shear stress, and that patient will die. If you try to recruit that patient, it is not a patient that you will want to recruit. So the ideal patient that you want to recruit would be a diffuse infiltrate. Okay, a diffuse infiltrate, not a lobar single infiltrate. That patient you will not want to recruit them by doing recruitment maneuvers. That patient might benefit with a prone ventilation rather than a recruitment maneuver. Are you understanding this? So the first thing is do no harm. That is why recruitment maneuvers, you should be very careful. The second patient that may not respond to a recruitment maneuver is the person with a very high extravascular lung water index. Now, what is the extravascular lung water index? If you go to the ICU, there is this cardiac output monitor that is attached. Now, at the moment, it is attached to bed number 12. One of the patients, Jagdish Lalwani. Okay, now that cardiac output monitor has got a figure in it called as extravascular lung water index. That is the water that lies outside the vasculature in the lungs. So that means to say, if there's a lot of fluid in the lung, at that moment a recruitment maneuver may not work. That is what it is found out. Okay, if there is too much of just fluid, extravascular fluid, that might not respond to a recruitment maneuver. So very high extravascular lung water indexes may not respond to recruitment maneuvers. Okay, when we talk about recruitment, means our FRC is already come down. When we talk about an ARDS lung, we no longer talk about it as a stiff lung. We talk about it as a small lung. The lung is very small, and you now want to increase the size of the lung. That is the reason that you want to do a recruitment maneuver. So A, recruitment maneuvers are not for everyone. Okay. B, you should figure out which is the recruitment maneuvers that you hey, how do you upgrade this Zoom? Yeah, the Zoom is almost going over. 10 minutes mein band hoega ye. I'll if it gets cut, we will I will initiate a new Zoom. Just join in on that. Okay. All right.
It is showing, sir.
Yeah, it is showing. Remaining time it is showing. So, anyways, I will send you a new link if it by any chance stops.
No, it will not get stopped.
Anyways,
Okay.
so what are the recruitment maneuvers that we know of? There are multiple number of recruitment maneuvers. I will first tell you what few recruitment maneuvers are. There is a recruitment maneuver called as SI. Old ventilators, 70s, 80s, 90s ventilators had got a maneuver called as SIGH, SI. So there was a button on the ventilator. If you press SI, it used to give a breath that is almost 3 times your existing tidal volume, after some 1 or 2 minutes. It was a timing related breath. We don't use those as of now. Sigh is something that you do when you're listening to a lecture. You make a big breath. That is because you want to improve your FRC. That is sigh. Okay, sigh is a form of recruitment maneuver which was there in older ventilators. Present ventilators don't have sigh, SIGH. It was a button that you pressed, and 3 times the tidal volume was delivered at a given particular time. Usually it is around after 10 breaths or 12 breaths, one breath is given in 1 minute or something like that. It is okay. That's a sigh. The second form of recruitment is called as tidal recruitment. Now, what is tidal recruitment? It is one of the most injurious forms of recruitment strategy. Most injurious. I would not even want to talk about it, but I'll explain to you what tidal recruitment is. Sometimes what happens is you are intubating your patient. When you intubate your patient, you use an ambu bag. Now, an ambu bag will deliver large volumes. The capacity of an ambu bag is 1200 ml. Okay, so when you give 1200 ml, there is a likelihood that the pressures in the lungs will increase, the volumes will also increase, and that will cause recruitment. It will open up alveoli, but it may not have, it will injuriously open up the alveoli. You can imagine a sudden force coming in, and the already inflated alveoli will inflate larger, and the smaller inflated alveoli will suddenly slide open. So there's a sudden change in pressure, and these sudden changes of pressures will lead to high pressures inside the lung. So tidal recruitment, you can easily increase the tidal oxygenation of your patient if you keep ambuing. This is what anesthetists do in the OR. In the OR, what do? They press that bag even more tightly, even more bigger, and they find out that the oxygenation is improving. Why does that improve? Because they are using high pressures and high volumes. We know high pressures and high volumes will cause injury to your patient. Not now, later on you will get this patient to go into septic shock. So what one person has done in the morning hours, by high pressure and high volume, you will find out in the evening or next day that the patient is going into multi-system organ failure because of the extreme inflammatory response that develops in these cases. Are you understanding what I'm telling you? And some lungs are so bad that they may also have barotrauma at that particular stage. So giving these large tidal volumes is called as tidal recruitment. It is not supposed to be done. It is a completely wrong method of recruitment. Because it does two things which are completely non-evidence based. One, increase of tidal volume. Two, increase of pressure. Both those things are harmful for the patient. Clear on that? Am I clear on that? Am I clear? Okay, so this is a strategy that's why if you see when you are intubating a patient, if you start ambuing them, their oxygenation will go up. But is that right? No, it is not right. It is causing more harm to your patient. Okay, I just explained to you that the shear that develops stress between two collapsed and opened alveoli will be so high that the pressures inside the lung will be so high that is more than 120 pressure, which will cause trauma, which will definitely cause trauma. And that is the reason that tidal recruitment is not something that you need to do. So there was a recruitment maneuver that was popularized called as the continuous CPAP or sustained inflation maneuver. Sustained inflation maneuver is called as the continuous CPAP method. If you ask me what is the what are we doing by recruitment? We are actually trying to open the lung. When will the lung open? When the inside pressure of the lung is higher than the outside pressure. That is when the lungs will open up. That means the alveolar pressure has to be higher than the plateau pressure. And this is called as the transpulmonary pressure. The transpulmonary pressure has to be high. And to get that means plateau pressure, that is alveolar pressure is equal to plateau pressure. The plateau pressure minus pleural pressure has to be high. Then only the patient will recruit. Then only the patient's lungs will open. Are we clear about this? But in order, so what is the common transpulmonary pressure that you and me in the body should have? Somewhere less than 12. Anything less than 12 anything more than 12, you will attempt to recruit the lungs. So in order to recruit the lungs, you need a transpulmonary pressure more than 12. So if you reach the transpulmonary pressure of say 30, then what is the and a pleural pressure is 5. What is your transpulmonary pressure? 30 minus 5 is equal to 25. So when you reach pressures of 25, you will recruit your lungs. At 12 transpulmonary pressure, you are safe. But if you want to recruit, which is an unsafe technique, you need to go more than 12 for that particular patient. If you want to recruit your patient, am I clear till now? For example, the ARDS lung, the pleural pressure of an ARDS lung average is 17. The average pleural pressure of an ARDS lung is somewhere around 17. Okay, this means if I give plateau pressure of 30, if I give plateau pressure of 30 minus 17, that is alveolar pressure minus pleural pressure, is equal to only 13, isn't it? 30 minus 17 is 13. So at 13 pressures, we may not open alveoli. We may not open alveoli. Clear on this till now? We may not open alveoli. In order to open the alveoli, we need to reach somewhere more than 20, somewhere more than 18. Okay, if you reach transpulmonary pressures more than 18, there is a possibility that the alveoli will open up. Clear? Am I clear till now? There is a possibility that alveoli will open up. All right, so that means the principle of recruitment is to increase the transpulmonary pressure more than 12, somewhere close to 20, then only your lungs will start opening up. If your transpulmonary pressures do not go more than 12, the chances of you recruiting the lung are less likely. Most probably, it will not recruit well. You are just giving oxygen, you are not recruiting your patients. Clear on this? So that's the principle of recruitment maneuver, transpulmonary pressure. When I'm increasing my transpulmonary pressure more than 12, 14, 16, 18, what is actually happening? Your end expiratory lung volume equal to FRC, or functional residual capacity, equal to baby lung, is now opening up. Your end expiratory lung volume is equal to the FRC, is equal to the baby lung. That is what is opening up slowly. Am I clear on this? Am I clear on this? So that is why you need to reach high transpulmonary pressures in order to recruit the lung. So in short, you must understand that when you're recruiting your lung, you're actually injuring your lung. You're actually injuring your lung. You understand? So if you're injuring your lung, I don't want to injure, I want to injure it less. I don't want to injure it more. So when you do a sustained inflation maneuver, what is the maneuver? I'll explain to the maneuver and you'll understand why it is injurious. Okay. So in a sustained inflation maneuver, what will I do? Whatever mode the patient is in, I will convert that mode from volume control, whatever we use volume control, we'll convert from volume control to a pressure support. We will, whatever if I have to leave it at whatever if I have to, if it's 100%, leave it at 100% if I have to. Okay. But you will convert from volume control to pressure support mode. Patient is paralyzed. In pressure support mode, switch off the backup, switch off the apnea ventilation backup. If you don't switch off the apnea ventilation backup, it will start ventilating again. Okay, your apnea ventilation should be switched off. What I will do is I will just stop the lecture and give you, if it doesn't upgrade on its own now, I will give you another link in 2 minutes, in a minute's time. Okay, if it doesn't upload now, if it doesn't continue, because it's saying less than 1 minute on my screen. All right. So, all right. So, what happens? The first step is you're going to ensure that there is no hypovolemia, there is no hemodynamic embarrassment, the patient is paralyzed. All this I've assured. And then what I'm going to do, I'm converting from a whatever mode the patient is to a pressure support mode. Okay, when you go to a pressure support mode, you have two settings: pressure support and PEEP. You are going to switch off the apnea ventilation. And then what you're going to do is you're going to increase